Today we have Dr. Ashura Buckley. Ashura Buckley is a pediatric neurologist and sleep medicine research physician at the Intramural Research Program at the National Institutes of Health. Buckley's research focuses on the role of sleep in shaping the developing brain, with a focus on abnormal sleep neurophysiology and severe forms of autism, obsessive-compulsive disorder, schizophrenia, depression, and other serious neurodevelopmental conditions. The ultimate goal of her research is to elucidate underlying problems in sleep-mediated neurotransmission early in the course of neurodevelopment, in the hopes of finding potential treatment targets. It's our extreme pleasure to have Dr. Buckley with us today, so without further ado, take it away.
Well, good afternoon, everybody. I'm so happy to see so many parents in attendance. And just up front, I'd like to say this is not a research talk. It's much more sort of a primer, if you will, about sleep in general. And you'll see that we're going to switch slides here, see if this is. We're just going to follow this outline pretty closely, go over some basic terminology, and then end up with what the current approaches are for the major sleep abnormalities in ASD and where we might go from there. So first, I'd just like to always start with this slide whenever I give a sleep talk. There are many definitions of what sleep actually is, and believe it or not, researchers can go on for quite a while parsing definitions. But in general, it's a reversible behavioral state where you're disengaged from the environment. And the most important thing for me as a researcher and for people to understand in general is that it's an incredibly dynamic process. So sleep is not at all stagnant, and especially during the early developmental years, there's a whole lot going on, and a lot of that we haven't really uncovered yet. And equally important for neuropsychiatric and neurodevelopmental disorders is that what's going on in the sleeping brain can both reflect the state, the health of the brain, and also can contribute to neurodevelopment. And oftentimes in neurodevelopmental disorders, that's an exacerbation and not a healthy contribution. So we'll start with some sleep terminology. So this is, I think, something that we all just need to be on the same page with. When people talk about sleep architecture, really they're talking about the basic structure, which is largely EEG-defined sleep stages. So how much time do you spend in REM sleep and non-REM sleep? And these are determined really by neurophysiology, and we'll get into that a little bit later. The ultradian rhythms, or what's going on, how the brain goes between those states at night. Is that fluid? What are the different proportions of REM sleep and non-REM sleep, and how do those cycles move throughout the night? Those are the ultradian rhythms. And of course the circadian rhythms, this 24-hour rhythm that we're very comfortable with, and we'll do a quick review of that. And the regulation. There are other sleep regulants like your prior time awake, and we'll talk about that briefly too. But the patterns, if you want to describe somebody's sleep pattern, that's really a combination of all of those things listed there, including, and I want to underline, the culture of your home and your environment, because sometimes we sort of ignore how much that contributes to sleep quality. So there's a circadian timing system and a homeostatic system. And generally we say that sleep is governed by those two things, and that is a push and pull between the circadian system and this homeostatic process. And there's this regulation of body functions with each other and with the external environment, and those are on a 24-hour cycle. The circadian timing system is governed by a large, huge family, really, of clock genes in these positive and negative feedback loops that regulate gene transcription and protein translation. And these proteins act as internal timekeepers, and they coordinate with Zeitgebers, which are these external clues, and the most powerful Zeitgeber is light, and that helps entrain the circadian system through suppression of the melatonin secretion through the pineal gland. But there are other Zeitgebers as well, most importantly food, so that's a very important Zeitgeber, and as well as social cues, which has particular relevance to populations of people with ASD. A little bit more on the circadian regulation system. This is just a nice little cartoon that shows you that there are many things in the body that are regulated on the circadian rhythm, including core body temperature, and you can see the second and third panels there show growth hormone, and cortisol have sort of opposite circadian timing, with growth hormone most likely to be elaborated during the first third of the night during slow wave sleep, and cortisol to come online early in the morning when your brain is most likely in rapid eye movement sleep. And these are just examples of sort of how we normally distribute these hormones throughout the night. This is a nice depiction. It's about 20 years old now, but it sort of just shows how we've conceptualized sleep for a long time, which is what I referred to this two-process model of regulation. So there's circadian drive, which is process C, and that combines with your process S. So what have you done in the 24 hours or the 12 hours or whatever it is before you're going to sleep? What have you been doing? What is your sleep propensity? And so you put those two things together and you end up with a nice little curve here, those two processes working together to give you a 24-hour rhythm. But we know that there's more to sleep than those two processes, because this bottom list here is very, very important. And in terms of neurodevelopmental disorders, maybe more important actually than the intrinsic rhythms. So what's going on behaviorally? We talked about social cues also being Zeitgebers. What's going on in your environment? And are there genetic abnormalities, perhaps even in your clock genes, that might actually override sort of those normal rhythms? And here's a very colorful and playful slide that I borrowed from my friend Jody Mendel that I really love, because it kind of just really speaks to me about all the things that have to go into giving you optimal sleep. And optimal sleep itself is a term that we haven't really well defined, but you can see all of those things that contribute. And the question for us is, where in that big picture does neurodevelopmental disorders, does intellectual disability, ASD, where does any of that fit in? And how powerful a change is that pink box down there? And we don't really know. So what I do is I look for sleep metrics that can be objectively measured and reliably produced. And I use the EEG to do that. And like we talked about, the sleep macro architecture, which if the slide pops up, will give us a nice EEG-defined state of being. So when you're alive, you're either in awake state, you're a REM sleep, or you're in non-REM sleep. And the brain doesn't like to spend a lot of time in between. Can you guys see my cursor there? Is that visible to you all? The brain doesn't like to spend a lot of time in between these states. And so you can get a lot of information about how fluidly or comfortably the brain is able to switch back and forth. And I'll show you a little bit about why that's important, starting with this next slide. This is a little messy here, but this just shows the four major centers, critical brain structures involved in the control of sleep and wakefulness. The hypothalamus, which contains nuclei that elaborate GABA, histamine, hypocretin, among other neurotransmitters, play a major role in the wakeful to sleep switch. Of course, the suprachiasmatic nucleus that we talked about, which is conveying circadian information received from the retina and onto the hypothalamus, and obviously involved in elaborating, releasing melatonin. And then we have the brainstem, which we have populations of aminergic and cholinergic neurons that are moving upward in the brain, synapsing in the thalamus, helping control the thalamocortical gateway, which we know the thalamus is a very, very important gateway structure for when we go to sleep, and blocking out external stimuli. So those are four major centers, and of course they can be subdivided into the different neuronal populations, different neurotransmitters. But one of the ways that we can get some insight into what's going on there is what we do in our lab and in other labs across the country, which is an EEG, which is a non-invasive way to get a sneak peek at these areas. And you record electrical activity from various areas on the scalp, and it serves as a proxy for that underlying neurotransmission. because all of these different brain waves, these different oscillatory shapes and sizes and frequencies, they represent different stages of sleep. And so what we do is we decompose those into sort of that cartoon on the lower right there, which is called a hypnogram. And we usually take 30-second by 30-second interpretations of these different oscillatory waves, and we recognize them as either being slow wave sleep, very slow wave sleep, which is stage 3, stage 2, which has a particular look to it and has particular populations of neurons that are busy, stage 1, which is very light sleep, and rapid eye movement sleep, which has its own particular characteristic of neurotransmitters, proteins, gene transcription, all of that wonderful stuff. And you can see here from the hypnogram that there are very well-defined patterns of the way the brain typically goes to sleep, its ultradian rhythm, and how you end sleep. And just for an example, you can see that deep purple line in the first third of the night. That's slow wave sleep, and slow wave sleep is heavily weighted toward the first third. And for example, those red lines are rapid eye movement sleep, heavily weighted toward the last third of the night. So that's what we expect to see. And again, just to say again that these different patterns of neurotransmitter activity vary by state, and the profiles are closely associated with different patterns: hormones, genes, proteins, membrane potentials, and oscillatory patterns. So when you generate a hypnogram, you're generating so much more information. This is just a little cartoon to sort of, if you pick one of these out, you can see, okay, REM sleep, very high in cholinergic activity, and in GABA and in MCH. And the patterns are different, and the neuronal populations, as you can see, the little cartoons under each state, are different as well. So different areas of the brain active during different states. So we know that much. What's very interesting to me as a neurodevelopmental person is that sleep not only changes throughout the night, but it changes across a lifetime in a very programmed manner, and it's predictable. So you can see this is a very old cartoon which still holds up, and if you take a look at the left-hand side here, you can see percentage of the day, that a 24-hour period that one might spend in any particular state. And across the bottom, you can see age. And so by preschool years, you've sort of graduated to what will become the rest of sort of the mature proportion of how much time you spend in non-REM, in REM sleep, and in waking. But early in life here, you can see that those stages and that proportion and the way the brain is sleeping is very, very different, and it rapidly changes in the first 5 years of life. And so the area that I'm most interested in is finding out what's going on during that period of time. Why are those oscillatory changes taking place? How do they represent the different maturation of the different neurotransmitter profiles, for GABA, for instance? And what I found over the course of the last decade and a half is that we have major gaps in our understanding about this process between sleep and neurodevelopmental changes. In fact, we have so little information really about the specifics of sleep. We know it's good for you, right? We know that when you sleep restricted, bad things happen, but we don't have a lot of objective data. This is just an example of a paper from 2016 where our best attempts are consensus guidelines, and this is a great document, and these are some of the people who have spent decades and decades of their lives studying pediatric sleep, but the best that we have right now are consensus statements, and you can see these are pretty broad too. We think that, between 4 and 12 you should get this amount, but it's pretty broad. In toddlers, this is the amount of sleep you should get, and by adolescents you should generally be getting 8 to 10. Again, there's a big difference between 8 hours and 10 hours, so we're really not quite there yet. So we usually reduce all that information that we have to sleep time, just like that consensus statement showed, and we say, okay, this is easy to measure objectively, so we'll give a window of what total sleep time should look like. It's much, much harder to measure and quantify sleep quality. One way to start to do that is to pick an objective measure and try to marry that to a behavioral manifestation. And so what we do is we look at objective measures of sleep, and what has been going on is researchers then compare them across populations in a cross-sectional manner. So for instance, you take all children who are between 3 and 5, and you take a look at them, they're typically developing, and you compare them to a bunch of children who are 3 and 5 who have a diagnosis of ASD, and you say, how do they sleep differently? So up on your screen is another picture of a hypnogram, just to remind you of what a typical hypnogram might look like. Deep, slow wave sleep in the first third of the night, lots of REM sleep toward cycle 5, and easy and smooth transitions in a nice step-like fashion. And of course, it'd be much smoother than that in real life, but in the cartoon, it's a nice stepwise fashion. And what I see a lot in my research is something that looks more like this. So when I'm looking at children who have neurodevelopmental disorders, a lot of times I will see frequent disruptions, what looks like an inability to transition between slow wave sleep and REM sleep, or between REM sleep and wake, and so you end up with these frequent arousals. And we know from animal studies that this is disruptive to learning and memory, to not have consolidated sleep. You get the amounts of both deep sleep and REM sleep severely compromised. And so we try to figure out, well, when we get the sleep disruption, how do we characterize that disturbance? Is it just fragmentation? So is that fragmentation coming from, say, another sleep disorder like obstructive sleep apneas? Is it an apneic picture, and we look there? Is it a movement disorder that's waking this child up? Maybe it's neither of those things. Is it some type of intrinsic restriction? Sometimes the pattern won't look quite like the one I showed you, but it'll look more like a child falls asleep at 11, child is up at 3, and does not go back to sleep again for the rest of the night. And so that, trying to chase down, is that restriction related to misalignment? Is this a circadian problem where if they were allowed to go to sleep, during the day, would it look different? Or is it a combination of those things? So that's just an overview of how difficult it is sometimes, even when you have an objective measure, to try to walk that back and figure out where the abnormality is coming from. So that said, most of the published work in ASD, autism studies, show that the major problem that people with autism are experiencing is one of insomnia. Now, over the last decade, insomnia has sort of morphed and changed the definition really to be pretty inclusive. And you can see the bolded letters there, the bolded words there, showing you that it's defined as it can be a persistent difficulty with initiation, it can be staying asleep, it can be consolidation, like these problems with sleep efficiency. You're in bed for 8 hours, but you're only really sleeping for a total of 7 of those hours. And the quality, which is, again, is a much harder thing to measure. It has to be in the presence of adequate opportunity to go to sleep, and there has to be some form of daytime impairment, which again is very difficult with people who have social affective disorder or for people who have other behavioral problems to try to figure out how much of that do you ascribe to poor sleep and how much of that is intrinsic, and sometimes you really can't pull them apart. The causes of insomnia and ASD are myriad. Right, so this is an adaptation of Dr. Beth Mallow's slides, and you can see that medical issues would have to be addressed first and always should be. Does the child have epilepsy? That's something that we have a low threshold for looking for. Is the child on a medication? That's going to be interfering with their sleep, and there are many medications that do interfere with sleep, one way or the other, increasing, decreasing. We talked a little bit very briefly about reasons for fragmentation could include OSA or obstructive sleep apnea or disorders of movement or sensorineural disorders like restless leg. So you really have to be looking very comprehensively when you're trying to figure out the cause of insomnia in a child or an adult with ASD. But the bottom line is really the most important one on this slide, which is that multiple causes may exist in the same person. So you may have a child who has epilepsy, who's on a medication, and both the epilepsy and that medication are interacting to either cause insomnia or other disorders of sleep. So usually there are no easy answers. Some theories of why insomnia is so prevalent in ASD. Some of that comes from work done with polysomnograms, where we have evidence that the brain is organizing differently, at least in terms of neurotransmitter populations. You remember how I showed you that hypnogram really reflects what the underlying neurotransmitter is. For instance, in our lab very early, many years ago, one of the things that we found was that our children who had ASD spent a much shorter time in rapid eye movement sleep. And so for us, that was speaking about some type of deficit in the cholinergic system. So that's the way that we sort of pair those things together. So is it just an intrinsic abnormality in neurotransmission causing different organization of the ultradian rhythms? Is it just circadian gene abnormality? And there's been a lot of interest in that, and hopefully more research to come. This question of abnormal melatonin production, I think the jury is out there. There have been some interesting studies finding that there are different melatonin profiles in particular groups of people with ASD, and other studies that didn't find them. So I think we don't know the answer to that yet. Of course, we briefly touched on medical co-occurring conditions. And also this interesting other Zeitgeber, right, the very powerful Zeitgeber of social cues. If you have difficulty reading social cues, then you're not in training the way that typically developing children are to, this is the time to go to bed, this is when I sleep. And that's a very powerful thing for the brain normally, right? This is the period of time when I sleep, this is when I get up. And that is often overlooked when we think about why it's so difficult sometimes to get children and adults with ASD on a schedule. So I think just to be really clear and sum this up a little bit, the bottom line is that insomnia is the major problem in ASD, and the most reliably objective, reproducible finding in autism research that is sleep-related is fewer total sleep time hours. So for every cross-sectional study that shows that, let's say in lab, we have a population of children who slept for 8 hours, the population of children with autism will sleep for 7. And that's very consistent. And that these fewer hours have major consequences. There's a great review here. I have it up on the screen. It was published in 2014. And it basically says that this decreased total sleep time correlates very nicely with and predicts social skills deficits, communication impairments. There are higher rates of stereotypic behavior, increased rates of overactivity, disruption, aggression, irritability, you name it. So we know that. So what do we do about it? And I think that that's where we are now, where we're trying to figure out what's the best way to address this problem, where we know that we need to increase total sleep time. We know we need to address insomnias because that results in better behavior. How do we do that? So this is a nice slide that I'll refer you to, the Autism Speaks Sleep Toolkit. Dr. Beth Mallow and her group at Vanderbilt have done a very amazing job sort of putting this together. And I think for a certain population of children who are amenable to behavioral intervention, this is great. But of course, I know from the poll that I took a look at before I started this talk that a number of you are parents. And so for every parent for whom behavioral modification works, I see probably 3 or 4 parents who have tried very, very hard for whom it doesn't. And so we're just going to briefly talk about melatonin. So I want to just start by saying that there are no approved medications for insomnia in children. And that's not unusual. It's very hard to have FDA-approved medication for children in general for many indications. But this slide sort of on the left shows you the over-the-counter preps that people get and use and the prescription preps that people get and use. The single asterisk shows FDA-approved in adults, and you can see that's a very select group, just those 3 over there on the right: melatonin receptor agonists, histamine receptor agonists, and orexin receptor agonists. The other medications have pediatric data available. In the interest of time, I'm not going to go through all of those research studies, but there are some pretty good studies. But none of them are approved by the FDA. So this is all off-label use. And for most people, it's just over-the-counter use, which is also why it's worth discussing. It is the most commonly dispensed hypnotic drug, and especially in very young children. So it has both a hypnotic and a chronobiotic effect, right? So you can give it, and we'll go into that in a little bit, you can give it at higher doses, sort of as a soporific or something to just sort of help you initiate sleep and go to sleep, makes you a little bit sleepy. Or you can give it in lower, closer to physiologic doses as more of a chronobiotic to try to reset that circadian rhythm. I like to put this slide up here because although people think about melatonin mostly as a sleep aid, it has been looked at in various research studies for additional indications, including for headache, even though that sometimes can be a side effect for other people, and also some interesting research looking at its neuroprotective effect for children who've undergone hypoxic ischemic injury. So melatonin is a very interesting hormone. It does have adverse events associated with it in the various studies that have been done, and they're listed here. Most of them are rare, but the common ones are in bold. So if you're going to have a reaction to melatonin, it's probably likely to be in that list there. Headache, tired in the morning, people may feel a little bit dizzy. One that's not listed here but that I do see in my population of children is an increase in nightmares, which makes sense because it does change the architecture a little bit. It can increase rapid eye movement sleep. And so if you have any of those side effects, you may want to discontinue it. But I know a lot of people do use it, and it is a go-to. So what are the studies showing? So on this slide, I've just listed some of the premises that why people look to melatonin, because it's been fairly well studied, not in a very long-term studies, but fairly well studied, and it is used very, very commonly. So there's this premise that children with neurodevelopmental disorders have this delayed endogenous circadian clock, and that may be so for some populations. And so there have been 5 published trials in ADHD that had good results with a fairly large dose, 3 to 6 milligrams at bedtime, and significantly shortening the sleep onset latency. That's what SOL stands for there. Clinically, we, by consensus, consider 15 minutes or more a significant shortening. Just as a reference there, we consider greater than 30 minutes to try to get to bed as abnormal. So if we can bring that down by 15 minutes, we think that that's significantly an improvement. And a lot of these studies are showing actually 30 minutes or more, even on top of that. There's another premise that perhaps, and we talked briefly about this earlier, that there are some abnormalities of melatonin, either synthesis or secretion in children with ASD. Is it a lack of daytime elevation, or it's a later nighttime elevation, or whatever it may be? And so that was the basis for trying ASD and controlled release. That's what the CR is in that sentence there for ASD insomnias. And again, some pretty good results that yes, controlled release and also regular formulation does help with sleep onset latency in a clinically significant way. The doses range from 1 to 6. The studies that I have seen are sort of on the higher range, giving the best results. So again, because we don't have a lot of well-done long-term studies of sleep and sleep pharmacology in neurodevelopment, the most recent and best done study is a consensus guideline from the European Consensus Conference in 2014. It's still the best that we have out there, and they suggest that you consider melatonin for a prolonged sleep onset latency, which I have just defined as greater than 30 minutes. Interestingly, the minimum age is 6 months, so that's very young, and it can be used again as a chronobiotic, so to sort of reset your circadian timing system, and that's at a lower dose, or hypnotic. Importantly, on this slide, I will point out that the recommendation is that you try it for at least a month to see whether or not you've been able to entrain your body, and usually that also goes along with some behavioral modifications in the family to try to get sleep on track, and then you revisit it every year to see whether or not you actually need to continue giving it. So to sum up with melatonin, there are some pros and cons here. I'll start with the cons. So there are not very, very long-term studies in melatonin. But the counteracting that, the pros, the side effect profile in terms of an exogenous substance being given is very good. It does have minimal effects on sleep architecture. We talked about in some people it increases REM sleep and therefore nightmares. It can be given in low dose and liquid preparations. It's widely available and low cost. The direct con to that is that over-the-counter preparations, it's very difficult to know exactly how much melatonin you're getting, or even if you're getting melatonin plus something else. So the recommendation is that if it is available to you, to get a prescription-grade melatonin, to have it actually made at a pharmacy so you know exactly how much you're giving. Those are the ones I want to point out to you in the pros and cons list. And the bottom line is that it is still most appropriate to use as a chronobiotic in people who have a delayed circadian phase. But it is accepted and recommended that it is a reasonable choice in pediatric populations for ASD and ADHD who have sleep onset insomnia, who have either tried and failed behavioral medication or would use it in conjunction with behavioral, not medication, with behavioral therapy. So, quick summary of sleep and ASD. What I want you to get from this primer, and it's very, superficial, is that sleep is very complex. There are many, many neurotransmitters that sort of have to come together very finely and have to work together with your environment and with a healthy sort of day, right? You need to be exercising and eating correctly and all of those things that help you schedule your sleep. It's finely orchestrated. And that the behavioral pattern that you end up seeing is a result of homeostatic, circadian, and external factors. Insomnia is the most prevalent disturbance in ASD. We don't really understand the etiology behind that, and it is likely that it is many, many different etiologies for different people. Behavioral modification may work. It does work for some, and when it does, that's wonderful. When it doesn't, melatonin is the best studied and has the best side effect profile. So that's not a lot. So this summary slide sort of, for me, very clearly points out that the future direction that we all need to go to is to answer those questions about sleep and neurodevelopment that we don't have yet. This bottom circle down here, the sleep-wake cycle disturbance, that's what we see, and that's what we talk about, and that's what we come to our clinician's office with. And obviously this double arrow here is to depict that the sleep-wake cycle disturbance is very much a feedback loop with neurocognitive neuropsychiatric impairment. There may be a common single genesis of both of those things, but continuing not to sleep well exacerbates the neurocognitive and the neuropsychiatric impairment, and we all know that. On the top there, you can see just 3 examples of what the etiology might be. You might have a clock gene abnormality. There could be brain structure abnormalities. I have populations of children who have brainstem abnormalities which directly and mechanically impinge their REM, non-REM centers, and that is depicted in both their behavioral sleep and also in their neurophysiology. You could have dysregulation of your neurotransmitter system. We looked briefly at the cholinergic system in our populations of children with ASD. Other people are looking at other systems. And what I want to point out here is that objective measurements, which is what's in that black box there, need to be more consistently and routinely incorporated along with the behavior, the sleep behavior, the neurocognitive profile, the genetics, the metabolics. Those things sort of all need to be married together when you talk about sleep, because otherwise you're not really getting a comprehensive picture. So it's a very difficult question to answer, why doesn't my child sleep, when you only have part of this enormous web filled in. And so being very cognizant of that and spending last decade and a half thinking about this problem, we got together with a group of researchers last fall, and we launched this project that I'm going to leave you with a link here. On the bottom is a summary of an NIH website, so you can see all the folks who came and contributed to this effort, recognizing that we do need to actually put all these pieces together in order to answer both the clinical and the research questions about mechanism of sleep disturbance, because it is so vital to quality of life The first meeting was held last September, and our task was to establish and create standardized protocols that will do exactly what I just mentioned, which is marry these objective electrophysiologic sleep data with behavioral phenotyping, metabolic profiles, and genes, and so that we can get a much more comprehensive picture, so that hopefully the next time I give a talk in the next couple of years and somebody asks, well, why won't my child sleep, they will actually have the information that I need to make a more reasonable conjecture as to why that might be. But so that's the state of where we are now. And in the interest of questions, I'm going to end there.
Okay, thank you so much. We did get a number of questions that came in, but please feel free to continue sending those through the chat box if anyone has more. So, Ashura, someone is asking about if there's any research, or do you know of the effects of cognitive behavioral therapy on sleep, specifically in adults?
Oh, that's a great question, and it's also another gap, right? So my research, I'm a pediatric person, and my research is primarily looking at children. I don't know of any research in particular about cognitive behavioral therapy in adults. You're talking about in adults with ASD specifically?
Yes.
Okay, so I know that there are some great folks who do CBT for insomnia in general, and that can be very powerful. I think it has to do probably with how impaired, and we talked about social cues earlier. Even for children who have ASD, CBT does work for a subset, and it just has to do with how amenable and how able you are to sort of follow the directions and go forward with the structure that's been put in place. I don't know of any studies in particular, but I can certainly reach out and try to make that available.
Okay, thank you. On one of your slides, you mentioned maternal stress or the health of the mother. Does this have an impact on the child's sleep?
I think we definitely.
And what's
I think that's okay. I'm sorry. I think we definitely think that it does. There is a wonderful researcher named Katie Sharkey, Sharkey, at Brown, and she focuses particularly on that. She has wonderful studies of women who have gone off medication for depression, anxiety, stress for pregnancies, and she's following both the mother and the children now. And she's just one researcher who I know who's focused on that. And so it absolutely does, both sort of, I think, perhaps genetically, but also the mother's ability to provide structure. If the mother is not sleeping in a healthy way, then it's hard for the infant to entrain.
Okay. I know that you focus on children mostly, but there was a slide where you showed ranges of sleep. Do you happen to know what the range for adults with autism is, what that range would be?
Well, that's an interesting question. Again, these are consensus guidelines, meaning that these are folks to the best of their ability and what they've seen in their cumulative 120 years or whatever it is that they've been looking at sleep, what they can come up with. I don't think that that's been done for adults with autism, so I don't have that information for you. Again, I will say that the most reproducible cross-sectional objective sleep metric abnormality is a decrease in total sleep time for people with ASD, and that's for adults and children. So, I mean, you could look at this and say, and again, I don't necessarily think that people with autism need less sleep, and that's the jury's out on that question. But they do tend to get less sleep. So this consensus guideline, you could say, holds for all people. It's just that there is something intrinsic in ASD that prevents that from achieving that sleep total. That would be the way that I look at it, anyhow.
Okay. We had a couple questions come in about over-the-counter versus prescription drugs, so I'll ask a couple of these. I don't think I saw it on your list, but do you know of any research about CBD oil for helping with sleep?
No, I don't. Nope.
Okay. Another one was about if there's a level of melatonin that might be too much, and if that would have some sort of effect.
So a level meaning like draw
a
blood level or dose? Yeah, I was surprised when I reviewed this literature, and we're about to come out with the American Academy guidelines for sleep in ASD sometime this fall. So we've been actively looking at and watching this literature. I was surprised when I first started looking about the doses actually that were given, because remember, a physiologic dose is so much smaller, but most of these studies use a hypnotic dose. So in one study, the modal dose was 7 milligrams, and people are using up to 10. So I haven't seen a dose response like for headache or for anything adverse event, and I don't know where that limit is. I do know that I'm a little uncomfortable with going above sort of the 6 or 7 or even 5 milligrams, because it is so much higher than a physiologic dose. And very, very long-term studies on the effects of melatonin, say on the HPA axis, haven't really been done. Again, it has a great side effect profile, but yeah, the upper limit is something that I think hasn't been established.
Okay. And then we also have another physician on the line that's asking about a prescription drug called Melatonin. And if you know anything about that, if it might be more reliable than over-the-counter melatonin?
Yeah, so manufactured receptor agonist, melatonin receptor agonist. I don't have the study in front of me. I know that people have used it. I don't know if it's been used in ASD. There have been any good studies in ASD. I'm thinking perhaps Beth Mallow would know the answer to that, and I can either give a shout out to her or post that on the site after. But yeah, I mean, anything that I think the issue with Melatonin is that it's expensive, and it works the same. I can't remember if it's an MT1 or an MT2. I think it's an MT1 receptor agonist. But I think the issue is that anything that's formulated like that is not going to be low cost, and so people would probably opt for over-the-counter.
Yeah. Okay. So another question, this is sort of shifting gears. Do you recommend having a sleep study done on an individual with autism who's 12 years old to better understand sleep problems?
I think that's a great question, and it really depends on what your concerns are. So the pediatric indications for sleep study are few, right? Obstructive sleep apnea being the major one. And there are some studies that suggest that people who have ASD have a higher rate of obstructive sleep apnea, and whether that has to do with hypotonia and a laxity in the tissues of the throat, I don't know, and I'm not sure if that will hold out in future. But there's some thought that maybe there's a higher obstructive sleep disorder, apnea sleep disorders in people who have ASD. So that's one indication. Another indication would be a young child who you think has restless leg PLMS but can't really tell you about that, but you have a clinical indication that they might, and you would do that in conjunction with iron studies. And the third sort of more rare indication would be if you thought the person had narcolepsy. So there are some sort of standard indications for sleep studies in the pediatric population. That said, my research questions are much broader than that, and so I would do a sleep study on someone who has clinical indication to have sleep disruption to see if I can find any signals in their electrophysiology that might point me to why their sleep is so difficult. So those are mainly now done as research questions. I think it would be hard to get a sleep study done without one of those three major indications, because it is not indicated for insomnia at this time.
Okay. Someone is asking about insomnia and it being considered a disorder of hyperarousal, which might explain the link between sleep issues, autism, and ADHD. Do you have any thoughts on that or more information?
Yeah, I mean, I definitely have heard that, and I think it's possible. Again, the terms can be very loose and misleading, and insomnia, as you can see, is a very broad definition. So in somebody who has, say, for instance, a difficulty not with initiation but maintenance, perhaps that's a disorder of heightened arousal mechanisms. But the person who has insomnia, who just has really terrible sleep onset latency, that could be something else. So it's possible. Yep.
Do you have any recommendations about the kind of physician that someone might consult with about sleep issues for a teenager with autism?
Yeah, that is an excellent question. And so one of the things that I try to do is to reach out to as many psychiatrists who are seeing adolescents as possible, because what I found just talking to the community is that many psychiatrists who take care of adolescents, their primary complaint is sleep issues. So I think that may be somewhere to start. A psychiatrist who sees adolescents has probably good experience with sleep disorders.
Okay. So we've been seeing this a lot, and someone asked this question about measuring sleep through gadgets like Fitbits or Misfit trackers. Can you talk a little bit about that and if that's a valid method and maybe where you see that going in the future?
Sure. So they are very popular, and I think that they definitely have their place. They are easy and they're fun, and they're like actigraphy. They are a proxy for sleep and wake. So they're not going to answer any research questions about the neurophysiology or about even the etiology about why somebody isn't sleeping well or about how they're not sleeping well. They can do a good job of tracking of tracking change. For instance, we might use an actigraphic type measure like that if we're going to do an intervention, because it'll give us an objective look at a before and after. But in terms of trying to define a sleep problem, yeah, I think not so much.
We had a few people ask about co-sleeping and if that's recommended, and is there a certain age where that should stop?
Right. So I should preface this by saying I'm not a behavioral pediatrician in any way, and also that there are some academy guidelines, pediatric academy guidelines, and there are some people who feel very strongly about co-sleeping. I'm not one of those people. I tend to think that people have very different environments, cultural environments within their home, and by culture I really mean the culture of the home. And I think that is a very personal decision, as much made by the needs of the child as the needs of the family. So I'm going to leave it at that.
Okay. What about research into screen time and if that affects sleep? Because I imagine that might be an issue with teens or even young ones nowadays.
So again, that is not my area of expertise, but I do have friends who study just looking at that, and the consensus is that absolutely that bedtime should be bedtime, and there shouldn't be any screens at all, at night, and especially because melatonin release is suppressed by light, and especially blue spectrum light. So I know there have been these studies that look at ways to sort of filter out the blue light, the blue spectrum light on your gadgets, and I'm not sure what the results are there, but people are definitely looking at ways, knowing that it's very hard to take an iPad or a phone away from a teenager, ways to sort of mitigate that effect on melatonin release. But I don't have those studies at the tip of my tongue.
Okay. Someone was asking about, you mentioned a study at the NIH, and if you're recruiting for that study, or maybe if you could expand a little bit on it.
Right. So the NIH study, are you referring to the link at the very last? If you're referring to the link on the very last slide, that was a workshop, and we published sort of the talks and the outlines of the gaps in research that we need to move forward as a multidisciplinary, cross-collaborative group to get the answers to these questions. The protocol that will come alongside of that has not started, but that is hopefully a characterization protocol of both typical sleep and children primarily, at risk for neurodevelopmental disorders and what their sleep electrophysiology looks like. We hope to get that study recruiting either late this year or early in 2019, but that is not up and running yet.
Okay. So I guess we've gone through quite a bit of these. If anyone has more, please send them in. But maybe if you could just describe something that you're excited about for the future specific to your research.
Right, and so that would be this ESP protocol, which is the electrophysiologic sleep phenotyping protocol that I'm launching in conjunction with my collaborator and good friend Audrey Thurm, who will be doing all the deep phenotyping of these children. And again, we just have this incredible lack of knowledge between 0 and 5 about how does objective sleep metrics relate to behavioral manifestation of developmental abnormalities, and what does it look like in a typically developing child. And along with those collections of the electrophysiologic measures and the deep phenotyping, we will get genetics, especially looking for the clock genes that we talked about, and metabolic profiles, as well as all the contextual sort of evidence that we talked about in the environment. We know so little about the way that sleep reflects itself in behavior, just on a sort of a typically developing trajectory. We need to know much more. We'd like to create that library so that eventually we can take a look at these hypnograms, if you will, or we can recreate coherencies, different patterns that the brain fits together during sleep that will help us see well before behavioral manifestation that maybe we're not going in the right direction. And so that's the goal, these electrophysiologic sleep phenotypes, to develop them. And hopefully we'll get started on that in the next 12 months. But I'm very excited about that. I'm very, very excited about working cross-discipline, and that was the beginning of this workshop in 2017 with computational modelers that help us dig into the reams and reams of electrophysiologic data that we do collect, and that in fact many people collect, but they're not really sure what to do with it, so they're sitting sort of on shelves in universities, and we've been reaching out to folks and gathering all that information because we do think that the answers are there, and some of them are probably low-hanging fruit in terms of these electrophysiologic patterns predicting behavior. We just haven't approached them the right way or in a team-like fashion. And so I'm very excited about working with my geneticist friends, psychiatrists, computational modelers, psychologists, people sort of all converging on sleep to get the answers for those of you who are on the line.
Excellent. Well, I think that's a great way to end this talk. We're excited for you and look forward to learning more as you progress.